Good morning. Welcome to Chapter 17, Neurological Emergencies. Be sure that you've clocked in to get appropriate time for this particular lecture, credit for the lecture. So here we go, Chapter 17, Neurological Emergencies. We do experience quite a few neurological emergencies in what we do. So this chapter will hopefully shed some light on how we can prepare to manage and deal with these kind of patients. All right, so stroke is one of the big ones on the neurological emergency. Stroke is the fifth leading cause of death and the leading cause of adult disability in the United States. This is according to the American Stroke Council or Stroke Association. It's common in geriatric patients, and we see it more often than we can believe, or more often than we want to on a weekly basis. All right, contributing factors for a stroke, there's several, okay? And there are several new treatments that are available for stroke patients. Seizures and altered mental status or other common neurological emergencies will also be covering those as well within this particular lecture. All right, so anatomy and physiology about the neurovascular system, neurological system. The brain is the body's computer. It controls breathing, speech, and all other bodily functions. There are three major parts that we talk about when we divide them up into parts. There's three of them particularly that we'd like to pay attention to: the brainstem, the cerebellum, and the cerebrum. The cerebrum is the largest part, and it has divisions. Okay. Here we go. This figure shows the slide. It's a cross-sectional representation or illustration of the skull and the brain. Here's your cerebrum, okay? Here's the skull, here, a little cross-section here. The brainstem is this particular area right here to here, okay? You can see it there to there, okay? And this is the spinal cord. Spinal cord, like we've mentioned, passes through the foramen magnum. This is the foramen magnum at this level, goes to the foramen magnum and runs on down the center of the spinal column, okay? And then it branches out to all the nerves, the different parts of the body. All right, so the brainstem controls the most basic functions, okay, the absolute basic functions, and the cerebellum controls muscle and body coordination. So, brainstem, major functions, okay, all your autonomic nervous system functions. And the cerebellum controls the muscle and body coordination, which is more relative to the peripheral nervous system. Messages sent to and from the brain travel through nerves, folks. We've talked about this before. There's 12 cranial nerves that run directly from the brain to the parts of the head. The rest of the nerves join the spinal cord and exit the brain through the foramen magnum. At each vertebrae in the neck and back, two nerves branch out from the spinal cord and carry signals to and from the body. I have a great representation. This is slide 9. It shows you how the spinal cord here passes through the foramen magnum and becomes the spinal cord, and wrapped around these guys are all your vertebrae, okay, of your spinal column, and how all of the branches of the spinous processes run off the nerves to deliver the signals to and from the brain from the different parts that they control. All right, so many different disorders can cause brain dysfunction that can affect the patient's level of consciousness, their ability to speak, voluntary muscle control. The brain is really most sensitive to changes in oxygen, glucose, and temperature levels. A significant change in any one of these levels will result in some kind of neurological change. All right, so headache, one of the most common complaints that we have out there. Oh, I got a headache. All right. Headache can be a symptom of another condition, or it can be a neurological condition on its own. Only a small percentage of headaches are caused by serious medical conditions. So thank goodness, most headaches are usually stress or tension related. All right, so tension headaches are caused by muscle contractions of the head and neck. They're attributed directly to stress. Pain is usually described as some kind of squeezing or dull or an ache in the head, and they rarely need any medical attention. Migraine headaches thought to be caused by changes in the blood vessel size in the base of the brain. Okay, the pain is usually described as a pounding kind of pain, with throbbing or pulsating. It's often associated with nausea, vomiting, can be preceded also by visual changes, and can last for several hours. So these suck. They're no good, no bueno. Sinus headaches, they're usually relative to an infection or pressure that's built up into the sinuses. And most people that have sinus headaches, they understand what they are because they usually have some kind of sinus problems. All right, so this particular table, 17-1, headache red flags. These are serious conditions that include a headache as a symptom. That could be relative to a hemorrhagic stroke or some kind of brain tumor or even meningitis. So this is table 17-1 on slide 15. All right, so stroke. Ooh, no good. A cerebrovascular accident, or CVA, a stroke, is an interruption of the blood flow to an area within the brain that results in loss of brain function. All right, so we have different types. The first one is an ischemic stroke. It is most common, okay? It is most common, accounting for more than 80% of all strokes. It results from a thrombosis or an embolus that's blocking the artery that's supplying that area. So symptoms may range from nothing at all to complete paralysis. Atherosclerosis in the blood vessel is often the cause. That little piece of plaque breaks loose, say from the carotid artery, goes straight to the brain, blocks off a little blood vessel within the brain. Now that area of the brain is not receiving any oxygen. No oxygen, no nutrients, nothing. So that's when that part starts to die, and we call that ischemic stroke. Okay, ischemic because it's being deprived of oxygen and it's dying cells. Right, so here you go. This is a diagram showing relative to the same. Here's a little blood clot here, and how it's cutting off blood flow to this part of the brain, kind of relative from where the clot originated from the aortic valve, and then it cut loose and went straight to the brain. All right, hemorrhagic stroke is a whole different animal. This is a bleed. This is when a vessel ruptures, so it accounts for about 13% of the strokes. So it's not as many as the ischemic. Cerebral hemorrhages are often fatal. And there are some risk factors that go along with that. People that smoke, people that have, high blood pressure that they don't tend to, they don't go see a doctor about it. They're just asking for it. All right, so Berry aneurysms are a common cause of hemorrhagic strokes in healthy young people. It presents as the worst headache of their life, and then eventually it ruptures and then causes a subarachnoid hemorrhage. That's below the arachnoid space, henceforth the name subarachnoid. All right, so transient ischemic attacks, TIAs. When stroke-like symptoms go away on their own in less than 24 hours, the event is usually called a transient ischemic attack. A TIA may be a warning sign of a larger stroke to come and is considered an emergency. About 1/3 of the patients who have a TIA will experience a stroke soon after. All patients with TIAs should be evaluated by a physician. All right, signs and symptoms of a stroke. There's several, okay? General signs and symptoms include facial droops, sudden weakness or numbness in the face, arm, leg, or one side of the body, decreased or absent movement and sensation on one side of the body, a lack of muscle coordination, we call that ataxia, or a loss of balance, sudden vision loss in one eye, blurred or double vision. These are all signs and symptoms of potential strokes. All right, so difficulty swallowing is another one, difficult level of responsiveness, speech disorders, difficulty in expressing words or thoughts or inability to use the right words, slurred speech, which is called dysarthria, and then sudden or severe headaches. Also confusion, dizziness, weakness, combativeness, restlessness, and tongue deviation and coma. All right, so left hemisphere. The stroke on the left cerebral hemisphere may cause aphasia, okay, aphasia. Basically with aphasia, it's the inability to produce or understand speech. Strokes that affect the left side of the brain can also cause paralysis on the right side of the body. All right, so right hemisphere strokes. Strokes that affect the right side of the brain can cause paralysis on the left side of the body. Usually, patients will understand language and be able to speak, but their words may not be or may be slurred and hard to understand. Patients may be oblivious to their problem. This symptom is called neglect. Patients with a problem affecting the back part of the cerebrum may also neglect certain parts of their vision. Neglect and lack of pain cause many patients to delay seeking help. Bleeding in the brain. Patients may have high blood pressure, okay? A lot of folks have it. They go untreated, and what happens is that once something ruptures in there, the high blood pressure may be the cause of the bleeding. It may be the cause by the bleeding as a compensatory response. A trend of increasing blood pressure is an important sign to take note of. Significant drops may also occur as the patient condition worsens. All right, so conditions that may mimic stroke: hypoglycemia, a postictal state. This is after the seizure has occurred. And then subdural or epidural bleeding from trauma. Here is your diagrams here. If you look at fractures, you can see, and this is incorrect. What you see here, this is an epidural. This particular thing right here, you see the dura is here, and it lines around this way. This should read epidural. This is a typo. Epidural hematoma. It is above the dura. But if you look at this one, this definitely is a subdural hematoma because it's below the dura. Okay, so epidural versus subdural hematoma. When we talk about over here, most of our epidural hematomas, okay, the epidural hematomas are caused by a bleeding vessel that's outside the middle meningeal artery, and you end up with a fracture. Somebody's gotten hit in the head with a baseball bat, and the blood leaks in from that crack, that fracture line, from the middle meningeal artery. It leaks inside, and it ends up on top of the dura, and it causes pressure on the brain. All right, so seizure. Seizure is a neurological episode caused by a surge of unorganized electrical activity in the brain. In the United States, it's estimated that 2 to 3 million people have epilepsy. So, generalized tonic-clonic seizure, this results from abnormal electrical discharges from larger areas of the brain. It usually involves both sides of the brain, or what we call hemispheres. It's characterized by unconsciousness and generalized severe twitching of all the muscles, and it lasts for several minutes or longer. This is not good. Generalized seizures are not good. They need to be oxygenated, need to take care of the airway. It's just not a good thing. Right, so absent seizures, this does not involve any changes in motor activity. It's characterized by a brief lapse of consciousness. They pass out. Okay, so there's no jerking and all that kind of stuff, kind of seizures. It's just an absent seizure. They just kind of disappear, and then they come back, and they seem to be staring off, and they don't necessarily respond that well until they get through that postictal state. All right, so partial focal seizures, one of two. Simple partial seizures, no change in the patient's levels of consciousness, right? This is called a local seizure. They may have numbness, weakness, or dizziness. They may have some visual changes or unusual smells or taste. They may also have, cause some twitching or brief paralysis, but it doesn't last for very long. All right, then you have complex partial seizures. The patient has an altered mental status and does not interact normally with his or her own environment. This is an end result from abnormal discharges from the temporal lobe of the brain. Other characteristics may be lip smacking or eye blinking very quickly, or isolated jerking of the extremities. Patient also may experience unpleasant smells or visual hallucinations, and then exhibit an uncontrollable fear or perform repetitive physical behavior. Aura. This is, patients may experience this. It's like a feeling of a presence all the way around your body. It's called an aura prior to having seizures. Sometimes that does happen, and it keys them in to be prepared to go through seizure activity. Generalized seizure, again, going back to it, sudden loss of consciousness, chaotic muscle, twitching, movement, and tone, and also apnea, where they stop breathing. Most seizures last about 3 to 5 minutes, and it's followed by a postictal state. They're absolutely worn out, and they may not know who they are for quite a while until their brain reoxygenates and they start to feel better. All right, so absent seizure, we already talked about that. It used to be called petit mal. It lasts for only seconds. Patient fully recovers with a brief lapse of memory of the event. Status epilepticus, this is seizures that continue every few minutes, okay, without the person regaining consciousness or lasts longer than 30 minutes. This is a true emergency. This can be deadly for a patient, okay, especially an elderly patient. Causes of seizures, there's several, but usually it's a congenital cause. They're born with a structural defect of the brain that causes seizures. It could be structural anatomy. It's something that's not correct in the brain or in the pons of the medulla. It could be a metabolic process, electrolyte imbalances, or it could be simply a response to fever, okay, febrile. Epileptic seizures usually can be controlled with some sort of medications. These patients generally know that they have seizure activity, know what's coming on, and hopefully they take their medication on a daily basis. If they don't, they may end up having recurrent seizures. All right, so table 17-2, common causes, type, epileptic, structural, metabolic, and febrile. It's a nice table. This is slide 39, table 17-2 in your book. All right, so the importance of recognizing seizure. Recognizing when a seizure has occurred, whether the episode differs from previous ones, identifying other problems associated with it, and you're basically just protecting their airway and protecting them from harm as the seizure runs its course. In the postictal state, it's following the seizure and the patient's muscles relax and the breathing becomes labored. Patients may present with hemiparesis, okay, that's paralysis on one side or the other, lethargy, or confusion. If the patient's condition does not improve, consider other problems such as an infection or hypoglycemia. Syncope, that's fainting. These are often mistaken for syncope. Okay, differences between a seizure and syncope is totally different. Seizure usually involves a longer term when syncope is just passing out and you don't lose consciousness usually. You just, it's a very, very brief moment. And usually it's related to some kind of cyclogenesis type of problem or some kind of orthostatic type of problem. Altered mental status. Aside from stroke and seizure, the most common type of neurological emergency that you're going to encounter is going to be a patient with altered mental status. Causes could include hypoglycemia, hypoxemia, intoxication, delirium, or drug overdose. Unrecognized head injuries, brain infection, body temperature abnormality, brain tumors, an overdose and or poisoning could be a variety of things, and it's your detective hat that is going to tell you. Let's see if we can draw that. Okay, your detective hat and your little magnifying glass, right? That's going to tell you what's going on here. All right, there's your little dude. Oh, I am so terrible. Little eyes, little mouth, and a little nose, right? Oh my God, that's awful. Okay, so there we are. So playing detective to determine what the common cause for altered mental status, because you're going to see a lot of these kind of patients. And it's either alcohol related, drug related, or they could have low blood sugar. So do your detective work. Make sure you find out what's going on with your patient and treat them appropriately. All right, causes. Again, we just talked about these. Hypoglycemia, delirium. Delirium is a symptom, not a disease. It presents as a new complaint. All right, temporary state, often with physical or mental causes that can be reversed with proper treatment. Other causes: head injury, severe intoxication, psychological disorders, medication complications, or infections. Patient assessment. Here we go for the neurological patient. Scene size up, same as usual. Primary assessment. All patients with an altered mental status should receive high flow oxygen. That way we can rule out hypoxia right away. Hyperventilation also may have several negative consequences, so you need to take a look at that, see what their rate and quality is. Get a good history on them, including psychiatric history. All right, so secondary assessment, vital signs, patients with intracranial bleeding, okay, may have increased pressure compressing the brain. They may have a physiological response to that, such as seizure activity or posturing. It can slow down the pulse and cause erratic respiration. Blood pressure is usually high, and there may be a change in pupil size. So let's take a look at those pupils. Always be sure with anybody with altered mental status to check blood glucose. All right, continue on stroke assessment. We have the Cincinnati pre-hospital stroke scale. Have them smile, see if there's any droop on one side or the other. All right, have them say a very simple word. It is very pretty and blue outside today. or you can't teach old dogs new tricks. Something, have them say something and see if you hear slurred speech. And the last one is you're looking for extremity drift. Help them hold their hands up, okay, like this, okay, and then, all right, have them close their eye, support underneath with your hand on both, and say, okay, I want you to hold that up for me, and then you'll slowly lower your hand down, and if one arm drifts down, that means it's weak. So that's a positive Cincinnati pre-hospital stroke scale. And there's several other Los Angeles 3-item stroke severity scale, fast mnemonic, and also Glasgow coma skull. And then you're going to do a reassessment every 5 minutes on these patients. All right, table 17-3, this is on slide 49, shows you that pre-hospital Cincinnati stroke scale. Good stuff, this is in your book, 17-3. All right, 17-4, that's your Los Angeles pre-hospital stroke scale. And 17-5, that's your 3-item stroke severity scale. This is slide 51. And 17-6, this is your Glasgow coma scale. Do make sure that you keep this handy. It's one of your tools that you're going to use, especially in your trauma patients, okay, in your assessment for neurological responses on trauma patients. And you also use it on your stroke patients as well. All right, so emergency medical care in general for suspected stroke patients. Physicians in the emergency department need to be notified immediately. Okay, we need to determine once they arrive if it's a bleeding stroke or if it is a ischemic stroke where there's a clot. So notify them, give them a stroke alert, heads up as you're headed to the hospital as soon as possible so they can prepare the CT scan so that we can get a CT scan, non-contrast, as soon as they arrive. Patients who have had seizures require definitive evaluation and treatment. So patients having a seizure need a bottom line, protect them from harm, maintain a good clear airway by suctioning, provide oxygen as quickly as possible. If head or neck trauma is suspected, consider spinal immobilization. All right, so emergency medical care for the headache, sudden onset of severe headache, sudden headache with fever, seizure, AMS. There's not a whole lot that we can do about this pre-hospital, but you can take a good history, a good physical, and then report this information to the hospital once you get there. All right, so emergency medical care for strokes, airway, number 1, maintain a SpO2 level or oxygen saturation level of at least 94%. Oxygen therapy is not recommended unless the patient is experiencing respiratory distress or showing signs of hypoxia. Thrombolytic therapy and methods to mechanically remove the blood clot can happen, but it needs to stop somewhere, but start between that 3 to 6 hours after the stroke starts. Otherwise, it's going to be too late. The damage to the cells are going to be too great. All right, so emergency medical seizures and acute medical type of problems, or AMS, altered mental status. The patient may be in a postictal state when you arrive, so you need to take that in consideration. And then, of course, you may have a patient who's actively seizing, and again, care for them is to be sure that they don't harm themselves. And then altered mental status, get a blood glucose. It may be simple as hypoglycemia, you just never know. All right, so that ends this particular lecture on neurological emergencies. Thank you for joining us. Make sure that you clock out to get appropriate credit for this lecture, and make sure you clock in and do your Quizlet for this chapter. All right, thanks again, and we'll see you next time.